Sounds like Dr. Heuser has the result from the case that he was working at so hard. So it sounds like we'll be able to start out with that and then move to the live cases.
That's great. Am I live?
Hey, Rich, we can see you.
Oh, great. Yeah, Mark, that's great. Yeah, thank you. We switched to our team was working diligently. We switched to a Asahi Estado 30-gram wire. And do we have the image? Can you see the image?
Yeah, we can see.
Okay.
So that's the point that you're at kind of just before we went off.
So we crossed into the true lumen and that contralateral approach. We eventually got into the true lumen and then switched with an 18 support catheter. And then, interestingly enough, we snared the wire and the support catheter. And now we're in good position. So we did everything now retrograde. Now we've accessed up and over to make sure we don't lose access. There we are up the aorta. Can you see that? That's with an 035 wire. And then we ballooned with a 7-millimeter balloon. And then first placed a balloon expandable stent right at the common iliac artery where it was occluded, because I wanted to be exact. I wanted to make sure we didn't, with the self-expanding stent, have a problem. And then placed a self-expanding stent, a Boston Scientific self-expanding stent, and then ballooned it. And then following this, we got a good result. That we're still left with that left common iliac aneurysm, but we fixed the total occlusion, and the team did a great job. Dr. Choi and the team did just fantastic.
That looks great, and I really like how you approached the most proximal vessel. You used balloon expanding, so you've got good accuracy and radial support, and you left the door open for any around the horn intervention you ever have to do in the future.
Yeah.
Very nice.
Thank you. Any questions? Okay.
Looks like no questions. You answered them all.
Thanks, Mark. Appreciate it. Team did a great job, as always.
Okay. So we have two cases that are going to be coming up from Asan Medical Center. Dr. Lee, I believe, is going to be ready first. We have a distinguished panel here who's ready and eager to go. And
이미지 1번 줘요. 이미지 1번이요. 처음에 이미지.
Okay. All right, Dr. Lee, we have an eager panel ready to see what you have ready to go here for us.
Good afternoon. I am from Chonnam National University. My name is Jae-Won Lee. Operator is a little bit changed. Dr. Seung-Whan is here. And I will introduce the case. This is a 57-year-old man was referred for diabetic foot ulcer. The lower extremity CT angiogram revealed total occlusion of all triple total arteries of the below the knee level, and he is an ex-smoker and has a history of diabetes mellitus. Next one. And actually, his toe ulcer is located on his left first toe. Next one. Ankle brachial index was normal. CT angiogram. Please show the CT angiogram on the screen. Yes, this is a CT angiogram of arterial case. Left side is a left leg, and you can see the diffusely totally occluded triple arteries of left leg with a heavily calcified region at the left posterior tibial artery, T-star. Have any question or some comment?
So what is your access point?
Actually, he already underwent coronary evaluation 1 year ago. So please show the aorto-iliac system, CT angiogram. 우회로 좀 보여줘요. 이렇게 쭉 이미지를 당기면 돼요.
아니요.
오케이, 저 위에.
위에. 아까
위에 좀 보여주세요. Because CT angiogram revealed a good aorto-iliac system, so today I punctured antegrade with a patient reverse position.
Which introducer did you use?
Yes, I will explain. Previous image.
Six French answer.
Could you
Six
show
French
the angiogram on the screen? Can you see? Okay. 그 전 거 보여줄래요? 그 전 이미지. 바로 전 이미지. 다음 이미지. 그 저장 안 했구나. This is a left SFA. I punctured the left common femoral artery directly with the Seldinger method, and I inserted next one. 6 French answers is to the palmitoral level, and this is today's angiogram. Revealed 3 upper arteries are all normal except proximal PTA subtotal stenosis. Next one. And this is a foot level angiogram, lateral view. Dorsalis is very good, and front arch is very well maintained, and there is some slow flow at the posterior tibial artery, but distal PTA is relatively good. The next one. And this is AP view of foot, AP cranial view. You can see the good connection, good acute artery, good arch at the pedal level, and medial plantar and lateral plantar branch of posterior tibial artery were intact.
Dr. Lee?
Yeah.
This is Dr. Ra.
Yeah.
This is an isolated simple BTK, relatively simple region in the isolated BTK. So
Yeah.
usual operator will use the 5 French anterior approach.
Yes,
simple,
because I heard, I heard that all triple arteries, triple arteries total occlusion is, Dr. Lee says. So I usually use 5 French sheaths, but I think that retrograde approach or sometimes transpedal approach will be needed for this patient. So I prepare today, especially 6 French, and I already prepared below the knee level for preparation for the retrograde puncture, but fortunately, only PTA level stenosis. Yeah, very simple.
This is not by your intention, but by the doctor, another intention.
Yeah.
With Dr. Ran, I usually use the 4.45 French to probably see in this case.
Even 4 French, 4.5, because the bigger the sheath size, we are limiting distal flow.
Yes,
not
sir.
good for the patient.
Yes, you are right. But antegrade approach, the main problem of antegrade approach is breathing control. More frequently occur after the sheath. But this patient is very lean and not obese, so I think breathing control doesn't matter. So I chose 6 French.
So I think those are good points. One of the things that we frequently do in our lab after an antegrade puncture is close with an angioseal. And since the smallest angioseal is 6 French, whether we use 4, 5, or 6, we're going to probably end up with the same angioseal. And also the choice of an antegrade certainly makes sense. You have a healthy appearing common femoral, you're going to be doing tibial work, and a relatively acute bifurcation of the aorta. So it looks like you're off to a good start.
Yeah, anyways, I rushed after lecture. I so disappointed to see this kind of discrete region because we wanted to show the latest technique in tibial BTK intervention. However, the region is so discrete, very rare case.
This is a very educational case because the CT angiogram, that is a people of CT angiogram. The arterial pace is too earlier than below the knee angiogram. So CT angiogram sometimes. Could you show the CT angiogram on the screen again? And as you can see, distal triple vessel is tapered very, very smoothly. So that is a sign of delayed contrast of ossification. So I think this is an educational case. Next one, next slide. So we performed the balloon angioplasty for the posterior artery. Next one, this is a lateral view. It's overlapped with the peroneal artery. This is an anatomic view. Next one, we have chose 3040 millimeters balloon for the angioplasty. This is after balloon angioplasty. 저장 안 됐네, balloon 한 개. Angioplasty, and as you can see, there is some dissection there. So next one. So balloon 한 개 전혀 저장이 안 됐다.
How long you inflated?
the first we inflated 2 minutes, and the second time we inflated for 4 minutes with 3040 millimeters balloon. This is the angiogram we had twice balloon angioplasty. 이게 마지막이죠?
네, 이게 맞죠.
Next one.
Next.
And we check
풋
the
찍은 거, 풋.
foot angiogram.
풋
after the
angiogram, last, 예.
last, 맨
예.
마지막 사진 좀요.
아, 예.
Next, 맨 마지막.
Next, 맨 마지막. 풋 이미지.
So a nice balloon result.
Yeah.
That's the Fusaro.
Yes,
In your
this is the
practice,
final.
would they get a drug-eluting
네,
stent?
그거요, 보여주세요.
I will show you the
in Korea, DB is not available in BTK region.
This is a final angiogram after repeated balloon angioplasty. The PK flow is a little bit slower than ATA, but much better than before balloon angioplasty. Previous one?
Previous.
Yes. So
Let me ask the panel something real quick. Would there be any thought of using atherectomy? It's a relatively short focal lesion.
Yeah,
At the same
yeah,
time,
yeah.
in a diabetic, there's going to be a high probability of having calcification. And I think possibly, one of my devices I like to use is a orbital atherectomy system or a short run. The chance of having a perforation or disc embolization is going to be quite low, and the risk of and just by making 1 or 2 passes with a 1.25 burr, I've seen good results without dissection. Any thoughts from the panel?
Very excellent comment, Michael. In this situation, maybe because the balloon response, we cannot predict the complete result like this. So focal atherectomy, we can try the silver atherectomy in the longitudinalism. Then we can do just a small balloon, the modification will get more nice result in this situation. But if we do the balloon angioplasty alone and fail to achieve very good patency, inevitably we have to put the stent. We have 2 self-expanding internal stents in the proximal tibial.
So Dr. Na, you wanted to put stand there, DS or something? No.
Before balloon angioplasty, you have relatively unexpectedly you got the simple lesion.
Yeah.
So maybe it was good chance to show
Next,
the
previous.
atherectomy and the simple balloon angioplasty.
First image.
Yes.
These days, I think the proximal SFA osteal disease, shorter lesion, and this proximal tibial short lesion, I'm thinking that maintaining the atherectomy, that is not derived from the very good clinical randomized trial, but in our daily clinical practice, I feel that it can be a very good result with the atherectomy, focal atherectomy, and plus balloon modification.
Okay.
But now the result looks acceptable.
Yeah, thank you.
In this situation, I usually 3 to 5 minutes wait and check again. Then
Oh, yeah.
the
Okay,
more
I'll check it
dramatical
again.
increase
Okay.
of the recoil, then we can finish. And one more important point is, I don't know the other panel's opinion regarding
줄여줄래?
we should open the distal pedal
좀 해줘, 좀.
arch
좀
or
두
the
개만.
post-tibial distal perfusion area, more aggressive balloon or not. So the problem is that this balloon response in the proximal is not so good. So distal injury, I think we are not sure that we can get quite good result at the small balloon in the distal PTA. How about that?
That's your question. Sometimes the when the throw is very slow, so and I touch the distal and the throw, and in this session I want to wait more several minutes.
I try to.
check again.
Yeah.
Then I want to decide.
But this angiography becoming more worse.
I think let's to change it.
The focal dissection
Yeah.
maybe 15, 20 minutes later will be.
Are there any panelists or moderator
Prescribe and
want to?
nitroglycerin something?
Yeah, we already give nitroglycerin before the intervention, and at this time I will give a little more.
Actually, because this is not a diffuse disease, so I don't hesitate stenting in this proximal focal lesion. The short 3 centimeter, 3 or 4 by 3, usually good result. And the distal patency is good, the stent patency is okay. So if the region is not so satisfied with the time, I think you can do the stenting.
I mean, if the initial strategy was to use balloon angioplasty, perhaps a low pressure inflation, let's say 2 at most 4, to see the balloon profiles. If it doesn't profile, you don't want to take the option of atherectomy away now, because as a second you can't do atherectomy. So just a low pressure inflation and see if there's a residual waste would be an option. But now you're kind of stuck because atherectomy is off the table. You know, we asked some of the American colleagues, Krishna and Mark, at your centers, how would you have approached this focal, possibly not Monday morning quarterback after you see after balloon dilatation? What would you have done?
The lesion has a number of favorable characteristics when you just look at it initially. It's short, it appears symmetrical, not heavily calcified. So I think you could make a good case for just trying balloon angioplasty, and then if balloon angioplasty doesn't look very good, then just drop a coronary drug-eluting stent. So I think that's how it would get treated in our lab. And you know, odds are this is going to heal up just fine, but I would probably just drop a drug-eluting stent in it just so I sleep a little better tonight.
I think this patient doesn't have a claudication at the previous history, and toe ulcer is not so severe. So I think I don't want to put a stent here, just balloon angioplasty. I will try once more with long balloon angioplasty, low pressure, and if the dissection remains, I will stop the procedure.
Now, this may respond very well just to additional angioplasty.
Okay.
In Korea, the drug stenting is available in the intervention.
Coronary drug-eluting stents cannot be reimbursed. No insurance. So
Two.
practically, only we can use the balloon expandable chromostit from Medtronic.
오퍼레이션, 오퍼레이션.
Maristive and export.
오케이, 이거 좀
two
저장해
surface
주시고요.
stent is available.
Save the floor.
So focal lesion, I think the surface lesion stent is a good
Timer.
Timer.
in our situation.
So how long will you leave that balloon up?
I will 5 minutes. Okay, so you can go another room.
So it sounds like while we're waiting for 5 minutes to pass, we're going to go to the operators in the other room. Dr. Urasawa and Dr. Cho are ready to go, I believe, in the other room. So we'll come back.
Okay, let's go.
Good afternoon.
Good afternoon.
So Dr. Urasawa, we are eagerly awaiting your case here. You have a panel that stretches from side to side in the auditorium, ready to see what you've got for us.
Okay, maybe we should have a case presentation first.
Yeah. The patient is 71 years old gentleman, and he has long-standing history of diabetes and hyperlipidemia, and he has received successful PTA at right pannitial artery and anterior tibial artery and peroneal artery 2 months ago, and now the patient complained lasting left leg pain and follow-up low extremity artery Doppler revealed recurrent severe stenosis at right anterior tibial artery. So we planned PTA again. Dr. Urasawa says.
Okay. So this is the case. Actually, the patient has an ulcer before, and they try a first endovascular procedure for below the knee arteries and also pop, occluded pop. They would successfully recanalize. They successfully recanalized the pop and also ATA and the peroneal artery, and the patient has cure on his foot ulcers. But after 2 months, he came back with lasting pain, and they checked the blood flow on the BK and they found out there was re-occluded BK arteries. So today is a re-intervention. So can I have the first slide, please? First image.
So I have a question from the previous procedure when the ATA was open. Were the vessels in the foot adequate? Because it looks like you've got very little to work with distally from the angio that we just saw.
I don't have any previous image information. So I'm sorry about that, but this is the first image I took today. Superficial femoral artery seems to be okay. There was some minor stenosis at the middle, but there may not be a problem for downstream blood flow. Okay, next one, please. This is the BK artery. We took the DA image, but it's really hard to see the precise information of BK arteries, so we switched to DSA. Okay, next one, please. This is DSA, upper part of the BK arteries. There seems to be a still open ATA, proximal portion, and occluded peroneal arteries and tibial trunk. There is no information about the posterior tibial arteries from the beginning. Okay.
So it looks like an old dissection there at the proximal ATA.
Yeah, maybe yes. This is the last picture I took today. The distal part of the BK arteries. The proximal part of the ATA is open, but the distal part is occluded. That is the major cause of the resting pain of this patient, I guess. So the target today seems to be a distal ATA occlusion. So what do you think? Is there any comment from the moderators or commentators? The important point is this patient is Rutherford 4, not 5. Right now, the patient does not have an ulcer.
Dr. Urasawa, did you have information about the circulation of the foot more specifically than that? I mean, did you look at the foot?
The distal part?
No.
Okay, I'm going to take that. Let's do it. Okay.
Yeah.
There we go. Stay there. Stay there.
다리
Don't move.
움직이지
Don't move.
마세요. 다리 아프시도 조금 참으셔야 돼요. 다리 움직이지 마세요.
Yeah. Okay. Yeah. Accent. So there is the frontal arteries, open frontal arteries. So supply the blood from collateral circulation from ATA and so I plan to recognize distal ATA occlusion today and see what's happening below the ankle area, whether the blood flow is increased compared to the original angiographic images. So if I have the time, maybe we should try a peroneal artery because peroneal artery was once opened in the previous endovascular therapy. So maybe easy to recognize the occluded arteries because they're just 2 months before.
Dr. Urasawa?
Yes.
This is Dr. Ra.
Yeah, hi.
Yeah, good to see you.
Good to see you again.
I can see the last image, we can see the PTA stump, right?
That's right.
Distally.
Yes.
But cannot clearly see the ATA distal. Can you see ATA?
Just a little bit.
Not
sure. Yeah.
So you will, it depends on the wound, the patient, which artery is more angioedema-oriented now, the ATA or
Well,
PTA?
as I said, right now the patient does not have an ulcer. Rutherford 4 cases.
Claudicant.
That's a resting pain.
Resting pain. Okay.
Yes.
Rutherford 4.
Yes.
So you will, in this situation, I think it will be more easier to open the PTA. How about it?
Well, in a previous intervention 2 months ago,
previous intervention.
yeah, they recognized the ATA to the dorsales pedis.
Okay.
So
once you will start the intraluminal attempt, then if you are not so comfortable, you will change it to different strategy.
Yeah, maybe yes.
Yes,
Maybe yes.
Okay.
Yeah.
Okay.
So maybe we should try first. Can I have a corsair?
Corsair?
Yes, corsair.
Okay.
And regalia wire?
Regalia.
A short one.
So you'll start with a hydrophilic,
Yes.
low-profile wire, is that correct?
Yes.
So hopefully you'll be able to find what was open before.
Yes.
Capitalize on the prior benefit. It seems that with neointimal hyperplasia, that's often the case, that the arteries can look, if you had a decent result before, they can come back looking terrible.
So if possible, I'd like to see the previous, the final angiogram. But unfortunately,
Slide shows the diabetic foot also.
Yeah.
Big toe ulcer, no ulcer now.
It's not correct.
So please tell us the name of the wire and the supporting device.
In the previous intervention? Today?
Yes.
This is the microcatheter is Corsair. And the guide wire
Corsair PV?
is a Corsair PV or Corsair coronary?
Coronary Corsair.
Coronary.
Yeah, maybe coronary. Can I have the one guide wire again? Yes. Okay. Yeah.
Corsair 150?
Yeah.
And wire?
Regalia?
Regalia 1.0.
And you indicated that on the prior intervention, the perineal had also been
Yes.
opened. Is that correct?
Yes, correct.
Actually, in Korea, the Corsair cannot be reimbursed. Very expensive.
Really?
Only we are using in the coronary CTO. So generally, we are using the peripheral microcatheter like the CXC14 or the Rubicon from Boston
really?
and the Trailblazer from the COVID. And we have 3 microcatheters. They're more cheaper than the Corsair. That
Can
is
I have
our situation.
magnifications?
Yes.
So you're at one of the trickiest parts of the procedure right now, I think. Based on the appearance of that proximal vessel, the wire may shoot through or it may get into a false lumen right away.
Yeah. Sorry. First, I advanced the Corsair. Not yet. Oh, sorry. Where's the Corsair? You push the guide wire too much. Okay?
No.
Yeah, there you go. Okay. Can I have one more magnification?
Yes.
Okay. So a little bit contrast medium.
Little bit.
Just do it. Yeah, seems to be some dissection here.
Already
Now.
tip has damaged.
Yes. It's okay. Yeah.
So that is your usual choice, or?
Yes, this is the usual
in
choice.
Japan? Okay.
What kind of wire you prefer in this situation?
So we have many options, but I personally prefer the Hydro ST or the Regalia, and once you enter the proximal system, we can change it to more. I'm these days frequently using the Command ES.
Command
From Abbott. Command
from Abbott. Yeah.
Yes, Abbott.
Yeah, I like that wire too.
Yeah.
Nice guide wire.
It's a great case. Good teaching points. Not a straightforward case by any means.
Yeah, you're right. Yeah, there seems to be some dissection here. So it may not be easy using this guide wire. Maybe we should switch to a little bit higher tip weight.
So what you would hope to see here is that wire kind of traverse the first 1.5 centimeters or so and then just shoot down the true lumen. It looks like it's not doing that.
Can I have more magnification?
Yes.
Okay. So take a shot. Just a little bit.
Yes.
Okay. Seems to be a dissection lumen. Right? So it's really tough to select the now.
It looks like a focal dissected area, right?
Yes.
So negotiation with the 1.0 gram will be difficult. Maybe you need more controllable wire.
Yeah.
Probably.
I agree. It goes to a subintimal space.
Yes. In Korea, we have maybe we have approach CTO 18 up to 25 gram, and also your Asai wire, Astata series, and also the Win wire, Win 80
Can I have a picture?
to 200.
Yep. Okay.
Yeah, you're in a different channel there.
Yes.
Just a quick thought about the contrast use.
Yeah, go.
DSA is good, but also maybe just half-half would be acceptable for these, just to kind of directionality. Also, it's very painful for the patient when you directly inject full dose contrast concentration down to the toes and you start moving. So just maybe half-half would be helpful to decrease the risk of.
Yes, that's a good idea. Good idea.
So it may have been tempting in the first part of this case to put a microcatheter down there and do a distal injection. That would have just extended the false lumen, I think, and made it much more difficult to get to this point.
Yeah, can I have the first image? DSA.
TSA.
Next one. Next one. This is 35 centimeter.
Yeah.
Yeah, 35.
35.
Yeah. So distal end of true lumen of ATS seems to be 35. Here. Could you remove
So you
this one?
frequently sending Corsair without wire?
Yes.
It's properly going.
Well, the purpose is, if you use guide wires, it goes to side branches. But if you advance microcatheter, it goes to a true lumen. That's the reason. We call it micro knuckle.
The routine procedure?
Yes, routine procedure.
Okay. That must be limited only for Corsair.
No.
Not other micro.
No. You can use other microcatheters. What's wrong way? Seems to be a 7 centimeter CTO. Let's try by regalia.
Yeah. Oh.
Can I have a filter, right side?
Yeah.
Filter. Yes. Yes. Much better.
You're in with the same wire, correct?
The same wire. Gently advance by clockwise and counterclockwise 180-degree rotations to prevent the side blanch. It's almost end of the CTO. It's not chronic total, just acute total. Uh-oh.
I think if you can successful wire with this regalia, I think the occlusion time must be not so long time,
Yeah.
right?
Yeah. Yes.
So that's why it can go. But the long
That's right.
real CTO, this cannot be done.
Yes, you're right. Well, in that case, I'm going to use Chevalier wire. It's not available in the collier, but it's a plastic jacket, 2 gram, but it has a very strong shaft. for this purpose, it's the excellent wire. It's a kind of collateral channel. Maybe we should take a picture. Okay.
Yeah.
Okay.
Picture.
Go. Don't move. Don't move.
움직이지 마세요, 아버님.
No. It's almost reached to the distal, right?
Yeah.
It seems to be subintimal. So this direction.
Yeah.
There we go.
Yeah.
No.
This contrast media is isosmolar,
That's strange.
Dr. Urasawa.
Pardon?
This contrast media is isosmolar.
I don't know.
Name of the contrast.
What kind of
They
contrast?
yeah.
Very big.
비슷해. The name of contrast media is 비슷해.
Bispak.
Yeah, 비슷해.
Very big.
Oh, that's strange. Again. Okay.
Okay.
Don't move to it. Okay? Don't move.
움직이지 마세요, 환자분. 움직이시면 안 됩니다. 절대 움직이시면 안 돼요.
Huh. Seems to be subintimal space. Maybe we should change the direction up here. This way. Okay. So let's take a picture again.
Yeah.
Just a small amount is okay. Go.
아버님 다리 움직이시면 안 돼요. 움직이시면 안 돼요. 조금만 참으세요, 아버님. 다리 움직이지 마세요.
Seems to be a different. How strange. Now. But cruise wire is very soft wires. It's really hard to get out from the artery. So I think this wire is within a vessel. Maybe subintimal was still in the vessel rumen, I guess. It seems to be subintimal. Maybe we should switch to much harder wires. Okay. So what kind of all 14-inch wires, harder wire do we have?
O 14?
Yeah.
V18?
V18 and O18.
일사니까 14?
Can I use a Miracle one?
Yeah. Okay.
Yeah. Miracle 6 grand. It's a corner wires Miracle. I'm going to use this.
I'm sorry, which wire are you going to now?
Miracle. Miracle 6 grand. It's a corner wire, CD wire. Sorry. Okay. Originally, I thought this patient is re-occlusion of ATA, so crossing the occluded segment might be easy, but actually it's not. It's not so easy.
Mark, any thoughts about the Viance and N-tier that's available in other geographies of the world?
What kind of wires?
So, we have what's called the Viance or the N-tier. It's very similar to the Crossboss and the Stingray.
Mm-hmm.
And the thought is, yeah, it's kind of basically the same principle, same device.
Stingray.
For peripherals, yeah.
Yeah. But in this case, we can see those are the spares. Maybe we can puncture that point if needed.
Yeah.
But the problem is this patient is Rutherford 4, not 5 or 6. That means too much complicated procedure may not be good.
And same as Corsair, the Miracle Series and Asahi CTO,
Yeah.
coronary CTO wire cannot be reimbursed in Korea.
Really?
So only we can use the dedicated peripheral CTO device.
Wow.
So
So-
not suitable for Korean society. Anyway, you can show the principle.
I'm sorry about that. Well, in Japan, there is so many different type of 014-inch wire for peripheral interventions. In my institution, we have more than 30 different type of guide wires, 040.
You feel free motion now, right?
Actually, it's not free, but I'm checking the feeling from the tip of wire. When you're advancing guide wire, you cannot tell anything, but if you pull out the guide wire, you can tell whether the tip is subintimal or true lumen because of some friction. So I really want to see the previous angiogram 2 months ago.
Yeah, that would be very helpful.
Yeah.
두 달 전에 여기다가 2달 전에 했던 거.
But the tactile sensation from guide wire tells me this is true lumen. Okay, can I have the picture?
Yeah.
Okay.
It looks like
어머니
the
움직이지
still
마세요.
in the subintimal space.
다리 움직이시면 안 돼요. 조금만 참으세요. 힘드신 거 아니에요. 조금만 참으세요. 조금 힘드시죠? 조금만 참으세요. 알아요. 조금 참아요. 조금만.
No. Too much movement. No. Okay, that direction. DA.
It looks like
TCTAP?
you're on 15 frames per second for fluoroscopy. Any thoughts of using 7.5 frames per second, just because these long cases, a lot of radiation exposure to you, and but maybe using the slower frame rate?
Well, yeah, maybe, yeah. Yes. Okay. DA? DA. No, DA. Because the patient moving. Okay? Just a little bit.
아버님 조금만 움직이지 마세요. 조금 다 다리 아플 거 좀 움직이지 마세요.
예.
Yeah.
Cannot clearly see the ATA.
But seems to be a right direction, I think.
I think why don't you try the subintim angioplasty using 14 or 18 wire? Otherwise,
it's not my way.
yeah, I don't feel any clue for the retroid approach either.
Yeah. Using what kind of wire? V18?
No.
Subintim angioplasty. If you want to do
below ankle, I prefer the 14 subintim angioplasty.
using a regalia.
Regalia also, all the usual command or regalia.
Command, yes.
Yeah, all the coronary, the fielder wire or anything.
Fielder. Fielder wire is almost regalia wire, same as.
Yeah. Or the 18 terumo wire. Or the 18 CTO wire, the loop, I feel a little bit bigger, so not so good for the below ankle.
Yeah.
The 14, yeah.
If this is unsuccessful, any thoughts about going after the posterior tibial? I saw it light up pretty well.
Yeah, this is another option, but again, and this patient is not Rutherford 5 or 6, just 4. So too much complicated procedure may not be appropriate. What do you think?
Yeah, the posterior tibial does look like a pretty small target.
Yeah.
You know, one of the other possibilities is, depending on how good the result on the perineal was on the last case, it looked like there may be an approach to the perineal.
Yeah. I think this is the dorsalis pedis, I'm sure.
Dr. Danzi, you spoke about tibial access. Would you agree that the posterior tibial is something that you'd be reluctant to go after?
You don't need you don't see very well the vessel of the foot.
Up, table up.
Yeah.
Okay, let's try. Okay, just a little. Go. Don't move. Please don't move.
움직이지 마세요, 아버님. 조금만 참으세요.
Hard to tell. Well, is there any suggestion in this situation?
If we want to stick to ATA intervention, I
Yeah.
think the only one way is the subintimal.
Yeah.
Or it would be better to go to Rutherford 4. You can go to PTA or just medical therapy.
Yeah, it's
exercise.
Maybe there is some discussion. Should be a discussion about Rutherford 4 case intervention, because right now we can use just a balloon, right? So restenosis rate at the 3 months is more than 70%. Most of the patients return to the institution with the same symptom, resting pain. So you have to repeat the procedure if you want to, but it's useless usually. So if the patient has an ulcer, big ulcer, necrosis, we have to recanalize the occluded arteries to fix the problem and obtain a cure of the patient's ulcer. But in the case of Rutherford 4, it's not. So you should not stick to the intervention too much, That's my opinion. Yeah. Okay. Which part of this artery? The final results?
Yeah.
This is the final result?
파이널.
Final result below the ankle.
Yeah. Below
Do
ankle.
you have the images from the
Final,
prior case there then? Is that right, Dr. Urasawa?
Yes. Ripped upper side seems to be the previous results, but this is the control angiogram, I guess.
파이널 발목 쪽에. 발목 쪽. 라테랄로 주는 거.
Oh, no. This feeling is subintimal, completely subintimal space. It's not good. Yeah. Okay. This is the onto tibial artery.
Yeah.
Can I have the another pictures?
다른 것 좀 보죠. ATA 쪽에 라테랄로 찍은 거죠.
Okay. Yeah, there is dorsal pedis. Big one. No, that's not good. So, yeah. Yeah, depend on the patient's condition, you should change the style of EDT. So if the patient has ulcer, definitely I go to the posterior tibial artery at this point, because that's the only one chance, remaining chance. Distal puncture of a posterior tibial artery and retrograde wiring.
So while you continue to work here, we're going to go back to the
Sure.
other room.
Okay.
We'll let you
Yeah.
work
Great.
with that wire.
Yeah.
We're going to go back and see
Yes.
how Dr. Lee and Dr. Su have
Great.
done. Thank you.
Thank you.
Okay, we're back with you.
Yeah.
How'd things go?
Yes, as expected, I already finished the procedure. And
She relaxed.
yes, can you see the angiogram on the screen? Can you see the angiogram? Yeah.
There we go.
Yes, after prolonged dilatation of the region again with low pressure, and
So that was your 5-minute inflation.
yeah, 5 minutes, 6 ATM, 4 ATM, and this is the final angiogram. Not so different, not so much. And final foot angiogram showed dorsalis is first flow, and peroneal and PTA is a similar velocity. It's much different compared with the baseline angiogram. This foot level angiogram is very nice. I will show the baseline angiogram. This is a pre-interventional foot angiogram. Peroneal flow give a cradle to the posterior tibial artery. So I finished it first this time.
So that's improved quite a bit.
So, have any questions?
Hope patient can be included in the 50% patency within 6 months.
Yeah, I think this patient is maybe not actually not ischemic food ulcer. I think combined neuropathic food ulcer because anterior tibial artery flow is very, very nice, and there is a good plantar arc. So maybe I think his foot wound will be recovered very well, and if even the stenosis occurred, foot ulcer will not recur, I think.
So do you routinely check a Doppler pulse in the lab when you're done?
Usually not.
Okay.
I think because the distal PTA flow is not so excellent, this lesion must be more higher chance of recurrence because distal flow is not good. So later on, once patients are coming with recurrence, I think it's better to open up the far distal together and also more aggressive managing in the proximal recurrence area.
Okay, because there is a heavy calcification. This is not totally occluded lesion. At this time, I didn't touch it. For the future, if the lesion is more diseased, more occluded, and also is more severe, I'll consider.
All right, thank you.
Thank you so much.
Results.
All right, Dr. Urasawa, we're back.
Okay. It's so
Didn't
quick.
give you much time.
Well, I can have the previous one.
So you've done an injection through your microcatheter?
Yes, the previous one. So I provoked the microcatheter to the position where I believed that this is true man. So and then advanced the regalia wire in a knuckle fashion, and then advanced microcatheter and the guide wire at the same time, and then push it. 7-inch mount porosity. It's a final method. And then I did a tip injection. Okay, because there was blood is coming from the microcatheter, and I injected. So now I try to dilate the segment using a small balloon. Can I have a coyote? 2 by 220. 220. Balloon, yes. It's the collateral channel to the frontal. Hold it. Okay. This side. It's manual trapping.
Manual trapping? At first.
I just hold the patient's leg and trapping the wire and remove the microcatheter. No, 220. Yes, that's right. That's correct.
So you'll dilate with a 2-millimeter balloon, so
Yes,
kind of flow
yes.
you can get into the foot.
Yes.
And then, I'm sure we'll run out of time before too long. Is your strategy then to go back and try to get the perineal open as well?
It depends on the angiogram. If there is some shortage of the blood flow to the below the ankle area, maybe we have to do something for perineality. But as I said, it depends on the time and the contrast medium for those kind of stuff, because this patient is not so severe.
Short.
No problem. No problem. Okay, not yet?
Not yet.
Not yet?
Yes. Not yet.
How about this? Not yet?
Not.
It's almost.
Yes.
Okay. So people try to use a long wires, 300 centimeter wires for, over the wire system, but it's actually not necessary. Okay, that's true. Okay. 1, 2, 3. 3.
3,
4.
4,
5. 6.
6.
7.
So the suspense is building, but unfortunately we're past time. So
Okay.
what we'll do is we'll let you continue to work here this evening, and then we're going to want an update on this case tomorrow. So
Okay.
we'll show the results tomorrow
Sure.
In the session.
Okay.
Thank you very much.
Thank you very much.